Natalie Rodriguez.
Stephanie Hersman.
Gerardo Gutierrez.
Judges, will you now introduce yourself with your name, academic degree, and current position?
Or else, okay. Brian Sick, I'm a physician at the university here. I'm the Associate Vice President for Academic Health Sciences.
Good afternoon, Chris Myers-Janda. I'm a VP with Premier, and academically, I have a master's in healthcare administration and an undergraduate degree in physiology.
Hi everyone, my name is Carolina de la Rosa Mateo. I have a master's in public health and I'm the director of operations at a nonprofit called ACER.
Good afternoon, Eric Maurer. I'm the Innovation and Strategy Officer at Kook. I hold a master's in healthcare administration, a master's in health informatics, and my bachelor's is in psychology. Thanks for your focus on Kook.
Got it, thanks. Hi, I'm Sophia Ali. I'm a family physician. I have an MD and an MPH, and I am the medical director at another FQHC.
My name is Paul Gehring. I'm a psychiatrist and do advising for startups.
Thank you. Let us know when you're ready and we'll start the timer.
Ready. Good afternoon. Thank you all for being here today. So we would like to discuss how we can rethink shared visits at Kook. Again, my name is Stephanie Hersman.
Natalie Rodriguez.
John Whelan.
Gerardo Gutierrez.
And here is a brief overview of what we will be discussing today. So before we can go into our pilot program and how we want to optimize shared visits, we have to look at some of the challenges at hand. So when we think about shared visits are best for patients who have complex social and medical needs. So we have to address those needs in order to best serve our patients. So when we look on a population level, Kook is located in Hennepin County, and here are some of the leading causes of death in this county. The two that we have highlighted here are heart disease and diabetes. Reason being is because we want to include these in our pilot study, which we will go into further in just a little bit. And we want to focus on these because Kook is a primary care clinic. We feel that these are both manageable and preventable on the primary, secondary, and tertiary level. So we've discussed some of the medical needs on the population level. Now we need to discuss the social needs. So we have to look at the social determinants of health. Kook serves a low-income population, so we have to take that into account. So we've discussed the population level. Now we are shifting our focus to more the individual level. So in the case study, we had patient B, who we have named here Maria, and here are some of the barriers to care that she experiences. She's Spanish speaking, she has mental health concerns, she has diabetes, asthma, so we want to take into account these concerns when building a shared visit model. So we've defined our problem as how can Kook improve shared visits to promote both health equity and interprofessional collaboration in light of scheduling, appointment length, and financial constraints. And as a team, we want to promote patient satisfaction, advance health equity, promote health literacy, decision-making inclusion, reduce barriers to care, and incorporate healthcare technology.
So now that we defined the problem and outlined our goals, we want to introduce you all to our solution. So this is Synergy Care, our pilot program. We value and celebrate interprofessionalism. Our name, Synergy Care, symbolizes the synergy and the efficiency of the interprofessional workflow, while the I Care represents our patient-centric mindset that we all care together.
Next, I'll briefly get into the enrollment of our program. We plan to enroll 200 existing Kook patients into our program. As Stephanie mentioned earlier, our patient population faces multiple chronic conditions, including cardiovascular disease, diabetes, and mental health concerns. We also want to focus on pediatrics, as we believe that investing in youth can create healthier adults.
So now that we explained the who, let us explain the how. Once the patient's in the clinic and deemed eligible by the physician, the patient will be handed an iPad. This iPad will introduce the patient to our AI avatar.
Welcome to Community University Healthcare Center appointment powered by Synergy Care.
Bienvenido al Centro de Atención Médica de la Universidad Comunitaria, impulsado por Synergy Care.
sida aad nooga soo galaan waxaad kulan kartaa qaar ka mid ah xubnaha kooxda caafimaadka.
As seen in the video, The AI avatar will be personalized and tailored to represent the patient's identity. We are going to promote inclusivity, diversity, while also tackling language barriers. So in the video you've seen, we've actually seen that one of the major languages spoken at Cook was Somali and Spanish, so we've demonstrated that through the AI demonstration. The AI in the pre-visit will also introduce the patient to the interprofessional team that they will be seen by. This will help in priming and educating the patient as to what to expect to lower any anxiety and prevent overwhelming the patient.
Now, the eligibility criteria for the shared visits will be determined by an Atlassian score. This Atlassian score is an algorithm that will be implemented into EPIC, which is the system or software that Cook already uses. Now, the Atlassian score is based on social determinants of health that patients at Cook might present, such as age, transportation, lifestyle, language, alcohol intake, smoking, or diet. Now, let's take a look at the score system. So if a patient scores a 4 or greater, then they're qualifiable for shared visits. It's very important that this only applies to patients who present multiple control conditions. Now, let's take a look at the eligibility criteria. Like I mentioned, patients that present uncontrolled condition qualify for shared visits. Now, patients who present multiple control condition and Atlassian score of 4 or greater qualify also for shared visits. Now, why do we target these two populations? Because at Synergy Care, we want to improve the patient's quality of life. Now, who is involved in these shared visits? It's the healthcare professionals that are in blue, such as the mental health therapist, pharmacist, social work, primary care provider, and the one in orange, the patient liaison. The patient liaison will be a resident, and the patient liaison stays with the patient throughout the whole visit. Now, the healthcare professionals, such as the dentist, psychiatrist, dietitian, and pediatrician, will be seen by the patient individually with a different algorithm score. Now, the scheduling will be done by the AI that will be implemented into EPIC. And this graph just demonstrates, it is an example of how different healthcare professionals will alternate in between patients. So let's take a look at Maria. Let's say Maria arrives at her appointment at 9 and her appointment is done at 10. We see that the patient liaison is with Maria throughout the whole entire visit. Now let's say the physician comes into the room and sees Maria at 9:15 and is done around 9:30. Then the physician will move and see Carlos, and they will see Joseph, and then it will see Tyler. Now, I mentioned that the scheduling will be done by the AI. So the AI will take trends in patient data. It will also schedule patients that present similar comorbidities in the same day. And also it will link to provider template and generate the time estimate of the appointment.
So we've talked about eligibility and scheduling to both maximize the provider's time and the patient's time. Now we want to talk about medical charting. So what we would like to propose is partnering with this dictation app called Nuance. What Nuance is that Nuance is a dictation app that takes the natural conversation between the patient and the physician. Reason that we want to implement this app is that we feel that it provides that interaction and that patient engagement and eye contact with the patient rather than charting and taking notes at the same time. It also automatically transcribes that conversation between the physician and the patient. And we also felt that it was the most inclusive as it is able to detect 86 languages and dialects. It's HIPAA compliant. It's already compatible with EPIC, so Cook wouldn't have to change their system. And ultimately what we want to do is reduce this physician burnout because we know that shared visits can be long and daunting.
So not only is our AI avatar involved in the pre-visit, but also involved in the post-visit. So once the physician and patient finalize their visit, the patient will receive the iPad again. Another important point is that so the patient will have access to their healthcare information and their avatar through the Epic MyChart. So once the patient receives the iPad, part of the post-visit, the AI avatar will actually give the patient a summary of the major points that were spoken about and anything overall, just an overview of the patient visit.
And finally, once these shared visits have come to a wrap-up, we want to have these multidisciplinary rounds so that each clinician can go back and talk about the patient cases. We want to have this interprofessional collaboration and ultimately deliver the best care to the patient.
All right, so next I'll walk you through the finances of our Synergy Care solution. We believe that pursuing value-based contracts is the best way to ensure the financial sustainability of our program. Unlike a traditional fee-for-service model, under a value-based model, we would be able to ensure our Medicaid population under contracts that would pay on a per-member, per-month basis. These capitated payments could then be used to reimburse our providers and build upon the managed care infrastructure we already have in place. This is made possible through Cook's partnership with FUHN, a community ACO. Through this organization, we can negotiate contracts with the Department of Health and Human Services on our integrated health partnership. Through this integrated health partnership, we establish these metrics of care quality that we expect to increase. And by increasing these metrics, we can increase our shared savings. These metrics keep patients out of high-cost procedures, and between 2013 and 2017, the larger organization FUHN, in collaboration with Cook, was able to save $23.6 million through this shared savings program. So looking at the developmental costs of our organization and what we expect this to be, we can look towards grants. So historically, Minnesota has been very generous in providing grants to Cook. Back in 2018, they offered $20,000 to improve our team integration and managed care efforts. We expect a similar grant would cover some of the implementation costs. We also look to offer a portion of our shared savings to develop the AI contracts. So this would be with Epic and Nuance. By offering a portion of our shared savings, this type of contract gets buy-in from our web developers, so they have stake in the success of our program. If we win, they would be paid. Other studies have shown that shared savings models and the visits are able to generate savings in other means. We're reducing no-shows by increasing patient engagement by an estimated 20%. We're also reducing insurance denials through the use of AI-facilitated dictation and coding. We're also increasing provider productivity. They're seeing more people in a given time frame, yet they're spending more time in a person-to-person, face-to-face contact because more of our documentation is being done through AI. We're also reducing duplicate services. If a patient's only coming in one time instead of multiple times, we're able to consolidate lab work. Next, I'll walk you through some of the metrics for our shareholders and some of the KPIs we expect to either decrease or increase. So first, with our patients and family. Going back to our value-based model, it's very important that we keep the continual improvement of our patient metrics, such as their ED visits, under control. We're also looking to improve patient satisfaction. A study out of Cleveland Clinic through their shared visit model found that most patients who tried a shared visit want to return. And through AI-facilitated patient feedback surveys, we expect to see similar results. Getting buy-in from our clinician staff is also going to be very important through this model. We expect that clinicians will have to collaborate, and we expect to have people volunteer to participate within the program. And this volunteer buy-in would allow us to make sure that we have the people that we need who are dedicated to the program. Of course, they'd be reimbursed, but just on a volunteer basis. Then looking at the finance team, we do have some increased responsibilities for them as they will be working through our payer contracts and the AI development contracts. Once again, with learners, we want to make sure that the University of Minnesota remains at the heart of Cook, and we hope that through the patient liaison role, we can bring in residents and potentially other students into a multidisciplinary learning setting. Finally, we'll look towards the board and community as we're always looking to improve our diversity efforts and serve the needs of our diverse population. We hope to that through our value-based contracts, we have this increased responsibility to uphold our values of serving everyone.
Now that we are revisiting Maria, this is one example of how Synergy Care could improve this patient's quality of life by addressing her mental and healthcare needs while also taking into account her cultural background. Thank you.